So I would like to ask you, with over 20 years of clinical and academical experience, what initially drew you to focus your research and practice on orofacial pain and oral medicine?
My practice in orofacial pain is, I think that in the next year we must focus on different point of view about this condition, because we have focused in previous years about the treatment of pain, but we consider the patients in complete way, and to evaluate all problems of the patients. So we are working on brain impairment of these patients. We work on mood disorder, on sleep disturbances, and in the near future we hope to find new way of treatment of these patients that focus also on the early diagnosis of cognitive impairment, and demonstrate that it's possible to treat these diseases with the right treatment.
Your work often explores the intersection between chronic orofacial pain and neuropsychiatric comorbidities. How important is an interdisciplinary approach when managing these complex conditions?
The multidisciplinary activity is essential to learn between us, the patients, because we learn from psychiatrists, neurologists, but also neurologists and psychiatrists learn from us, because know this type of patients that is different from classical psychiatrist patients. Somatic patients may exhibit different pathways, and the focus of symptom is most important. Probably we understand the differences in the response rate of the treatment is another answer, because our patients respond very well with different type of drugs compared with the psychiatric patients. For example, our patients respond very well to the treatment with the vortioxetine, but psychiatrist patients respond better with the treatment with SSRI or SNRI. But probably because our patients are different, probably in our patients there is a neuroinflammation, and vortioxetine works on neuroinflammation. But the collaboration is essential to improve knowledge about this disease.
Considering your lecture today, can you please tell us with a few words what is the burning mouth syndrome and how can it be treated or approached?
Okay. Burning mouth syndrome is the most common chronic orofacial pain condition in which burning is only the tip of the iceberg, because our patient is much more complex in terms of symptomatology, because patients may exhibit several symptoms such as intraoral foreign body sensation, xerostomia, sialorrhea, globus pharyngeus, and exhibit multiple medical comorbidities, psychological comorbidities, and cognitive impairment. So to treat the patients in complex way, we prescribed treatment to obtain a full functional recovery. Full functional recovery is that the patients return to a normal activity before to have the disease. So we treat the patients in complete way. The majority of patients now are in treatment with essential with two drugs, vortioxetine at dosage of 20 milligrams and pregabalin at dosage between 75 to 150 milligrams. And we added in the last time also melatonin 2 milligrams because melatonin is an antioxidant that increase beta amyloid clearance, so we prescribe these drugs independent to the presence of sleep disturbance.
So last question, what key advice would you offer to young professionals entering the field of stomatology?
Yes. For a younger professional, my advice is to learn about this disease, to learn about these patients, see many patients, because the practice to see this patient is the most important thing, and to study, because when as oral medicine specialists we must do diagnosis, but we must do also the treatment. So we learn the treatment for every disease that involve oral cavity.
Grazie mille for being with us on this Congress, Dottora, and we wait you with much pleasure to the next ones.